to the front lines of infection prevention, Lisa. Here, we don't just fight germs, we outsmart them with science, creativity, and a dash of humor.
Thank you, Dr. Lang. I'm ready to learn, but I must admit I'm a little bit overwhelmed.
That's perfectly normal, Lisa. I'll be with you every step of the way. And remember, in IP, every question is a good question. Well, let's begin. Your first mission today involves CVC rounding. Tell me, what do you know about it?
I know a lot about CVCs, but I don't have much clinical experience yet. Could you maybe refresh my knowledge?
Absolutely. Central venous catheters are lifelines for our patients, but they come with risks. Infection prevention starts with choosing the right insertion site, ensuring sterile technique during insertion, and meticulous post-insertion care. But before we embark on that journey, let's learn the basics. Welcome to the mystical art of vascular knowledge. Now, vein types are like highways. Peripheral veins are your local roads with less traffic. For example, basilic vein or cephalic vein. Deep veins are the highways with a lot more traffic. The ones that are used more often for CVC insertions are subclavian, internal jugular, and femoral vein. Central veins, the superior vena cava and the inferior vena cava, are the two great vessels, the hyperspeed lanes. They both empty right into the heart.
Roads and hyperspeed lanes. Got it.
Great. Now, what is a central venous catheter?
It's a thin tube, much longer than a regular IV. It's called a central venous catheter because it gives direct access to the central veins.
Correct. A central line is a long, flexible tube inserted into a vein in the neck, chest, arm, or groin. It delivers medication straight into the bloodstream. For any type of catheter, the vein is accessed with a needle, and the tip is navigated using ultrasound or fluoroscopy to the central vein. The one in the neck is called internal jugular vein insertion, often referred to as an IJ. The one in the chest is called subclavian vein insertion. The one in the arm is called peripherally inserted CVC or PIC. And the one in the groin is also known as a femoral vein catheter. The risk of infection from these lines vary by site. Subclavian lines have the lowest infection rate, and internal jugular and femoral lines have similar infection rates slightly higher than the subclavian lines.
Why not just give everyone a subclavian line in this case?
Well, a lot of clinical factors determine the type of line and the location of insertion. While the dressings are easier to maintain at the subclavian site compared to the IJ or femoral lines, there are several factors to consider. Placing a catheter in the subclavian vein is technically more difficult and carries a risk of causing a pneumothorax or collapsed lung. This risk might be unacceptable for very critically ill patients. Additionally, if a patient is coagulopathic and has a high risk for bleeding, this type of catheter might not be suitable because it's difficult to apply pressure to control bleeding due to the surrounding bones. Patients with renal failure may not be suitable for subclavian lines because they can cause stenosis or narrowing of the vessel, which could compromise future dialysis access. PICC lines are avoided in patients with chronic kidney disease for the same reason. They need certain vessels preserved in case they need future dialysis access.
Speaking of PICC lines, how do their infection rates compare to the three we just spoke about?
That is a great question, and the data is a bit hard to interpret because PICC lines are typically used in less sick patients. Critically ill intensive care unit patients often require CVC lines. While PICCs are used in ICUs, they're more commonly found on general wards or in community settings for vascular access. They seem to have lower infection rates because they're often used in less acutely ill patients. However, when they are used in ICUs, the infection rates are similar to those of the other three lines. So PICC lines should not be chosen just because we think they prevent infection.
Okay, that makes sense. I also heard we're supposed to avoid femoral lines because they're so easily contaminated. Is that true?
Yes, microbial flora in the groin is a concern, but respiratory secretions often contaminate and compromise dressings at IJ sites too. Femoral lines are typically used as a last resort when other sites are unsuitable. However, I should mention that in the setting of obesity, it is strongly recommended to avoid a femoral insertion site because of the skin folds and moisture buildup.
My next question is about lumens. Does it matter how many lumens a CVC line has?
That's a great question and an important factor to consider. Regardless of the catheter type, you can have CVC lines with single or multiple lumens. A multi-lumen catheter is a single catheter with more than one internal channel, also known as a lumen. There are double, triple, or quadruple lumen central venous catheters. The arrangement of these channels vary. As the number of lumens increases, so does the gauge and thickness of the catheter line. The larger the line, the more it will slow down blood flowing through the vein. Slow blood flow can lead to clot formation and increases the likelihood of bacterial buildup on the catheter. Consequently, catheters with more lumens have a higher risk of infection. In addition, larger, multi-lumen catheters can also cause turbulence and restricted blood flow, which can lead to thrombosis. That is why for any type of catheter, it's best to use only the number of lumens necessary for treating the patient.
Understood. Only use a number of lumens necessary for treating the patient.
Correct. Now I think we should go over the types of catheters, and then we can go do your first rounding together. Remember, each has its own superpowers. Each serves specific purposes, influenced by how long they'll be used, the patient's lifestyle, and the risk of infection.
Understood.
Let's start with non-tunneled CVCs. They can have 2, 3, or 4 lumens. They're quickly inserted directly into a vein without tunneling under the skin and are typically used for emergencies or short-term therapy in critically ill patients in ICUs. They're used for medications that need direct delivery to large central vessels, such as vasopressors or other treatments. Convenient, but with a higher risk of infection. Within the category of non-tunneled CVCs, here are some types of lines you might hear about, such as PICC lines. Placed in the arm and more durable, they are ideal for medium-term use, typically a few weeks to a month, though sometimes longer. They are easy to manage and generally have lower infection risks, but are not suitable for people with chronic kidney disease. PICC lines usually have 1 or 2 lumens. Another example are large diagnostic angioplasty catheters, aka Cordis. Due to their large diameter and an introducer port, a rapid administration of fluids, medications, or blood is possible, which can be crucial during emergencies. There are also pulmonary arterial catheters, known as Swan-Ganz catheters. They have a small inflatable balloon at the tip, which is inflated as needed to position the catheter or take measurements. They're used in ICUs to monitor pulmonary artery pressures and assess the right side of the heart's function. They're also used in cardiac cath labs for right heart procedures. These catheters are typically removed at the end of any lab procedure. Another non-tunneled CVC is a short-term dialysis line, also known as TempCath, for temporary dialysis, or a trialysis catheter when equipped with 2 ports for dialysis and a 3rd port for general central vascular access. This is used to administer medications in critically ill patients. The lumen of these lines is much wider to allow for a higher speed of blood flow required for effective hemodialysis.
Great. Thank you. These are all non-tunneled CVC lines.
Yes. Now let's talk about tunneled CVCs, designed for long-term use, for months or a year. They are surgically inserted with a tunnel under the skin to reduce infection risk, commonly used for hemodialysis, long-term chemotherapy, or antibiotics. Within the category of tunneled CVCs, you may hear about lines called Permacath or Hickman line. These are typically dual-lumen, long-term catheters that exit the skin at the upper chest. They are tunneled under the skin to enter the large veins of the chest, with the tip positioned in the inferior vena cava. Subcutaneous ports are implanted entirely under the skin, requiring minimal care with a lower risk of infection and suitable for very long-term access with the least impact on daily life. Most are used for chemotherapy. The port is accessed with a needle. In between times of access, it remains completely covered and protected. I'd also like to mention midlines, which are non-central lines. On a patient, they can look a lot like a PICC line as they exit the body at the upper arm, but the catheter tip does not extend all the way to the central vein. They are more durable than standard peripheral IVs and are used for medium-term access, usually lasting 6 to 14 days. Sometimes, as an alternative to PICC lines, they are used for up to 30 days. Some centers use these catheters to reduce reliance on central venous catheters and lower the risk of CLABSIs, central line-associated bloodstream infections. Also, midlines cannot be used to infuse medications that need to be delivered to central veins, like some chemotherapy agents, so your teams must be very clear on whether the patient has a midline or PIC in place. Recent studies comparing PIC lines and midlines show that midlines have a lower risk of bloodstream infections and catheter occlusions, with similar risks of line thrombosis as PICs. However, it's important to note that in these studies, PIC lines were used for longer durations.
6 to 14 days is a weird interval.
I think the assumption is before 6 days, the patient has a regular peripheral IV because using the larger arm veins for such short durations is usually unnecessary. Also, there is limited data on the safety of using midline catheters for very long periods, such as over 30 days.
Got it.
Oh, I forgot to mention one last thing. With PICs, we follow MAGIC guidelines, medical adherence to guidelines in children, and KDOQI, KDOQI guidelines, Kidney Disease Outcomes Quality Initiative. There's a QR code if you'd like to learn more.
That is so helpful. Thank you.
Remember, infection prevention starts with choosing the right insertion site, ensuring sterile technique during insertion, and thorough post-insertion care.
Got it.
All right, I think we're ready to start our first CVC rounds.
If only it was that easy.
I have every confidence in you. And remember, you're never alone here. Whether it's me or anyone else on the IP team, we're always here to support each other. It's a team effort, and the well-being of our patients is always our top priority.